Welcome, everyone, and thank you for joining our discussion on the development of the Seating and Mobility Index. My name is Julie Manline, and I'm a physical therapist at the University of Michigan who has specialized in seating and wheeled mobility for over 20 years. I'm currently the therapy supervisor for the wheelchair seating team. Today, I will be presenting our progress with Julie Harrison.
So I'm the other half of Julie Squared. I'm Julie Harrison. I'm an occupational therapist at the UPMC Center for Assistive Technology here, and also part of RST and research. So I kind of wear two hats. And today this will be my research hat.
This afternoon, we'll be discussing updates that we have made over the past year on our development of the Seating and Mobility Index, or what we call the SMI. We feel this will be a very useful addition to CRT evaluations that you are all already doing. We have to have this additional slide in that there is no conflict of interest being disclosed by either presenter. However, we do want to say we're very fortunate to have an amazing team of clinicians, researchers, educators, students, and other partners led by the experts at University of Pittsburgh. This afternoon, we plan to discuss the current limitations of CRT evaluations, methods, and documentation as it relates to current coverage policies, explain the development of the SMI, and provide details on our tool assessment process, and discuss our current status in the process of the development, along with some limitations that we've had. Is everyone excited? Woo! This project is part of a group of studies on disability and rehab research on healthcare policy managed through the University of Pittsburgh Department of Rehabilitation, Science, and Technology. This specific sub-project is part of a larger NIDLR Disability and Rehabilitation Research Project titled Assessment and Investigation of New Coverage Policies for Complex Rehab Technology Within a Contemporary Accountable Care Environment. I know that's a mouthful. This proposal was written in response to the voices of people with disabilities and providers of assistive technology who were surveyed and cited that funding and procurement was the most significant barrier in matching a person with appropriate assistive technology. So that was cited by the users. The research team led by Mark Schmaler and University of Pittsburgh is a collaborative effort between the Ohio State University, University of Pittsburgh, and the University of Michigan. This research involves 4 interrelated projects. They are designed to, number 1, evaluate current policies, both within and outside the United States, and gather stakeholder input. 2, develop a standardized assessment tool for equitable CRT procurement. That's the SMI that we're going to talk about today. Number 3, perform analyses of existing databases and registries relevant to CRT. And 4, evaluate the feasibility of a new CRT policy model. We are currently in the second year of the 5-year grant. The goal at the end of 5 years is to have a model plan that has been tested and can be implemented. Our aim is to eventually propose policy coverage and policy change that will be equitable, evidence-based, and considers the individual themselves, including objective measures of function, rather than coverage, which is based purely on having a qualifying ICD-10 diagnosis. This would include factors such as where people live, where they need to go, and what they need to do in their everyday lives. Ultimately, what we want to do is have our practice guide policy and not have policy guide our practice.
I'm about to throw a whole lot of words at you. So before I do that, I want to know how many people in here are therapists who do seating related things? All right, we have a bunch of you. How many of you are policy wonks? Got it. Okay. So the purpose of subproject 2 is to systematically develop a tool clinicians can use to assess and quantify a person's needs for different types of CRT, blah, 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 blah. Right? That's a whole lot of words. Let me break that down so you understand what we're talking about here. We're starting with tool for clinicians. So all you clinicians here, we're looking at you. We're trying to develop something that clinicians can use in their practice, specifically to assess and quantify someone's needs. So we want to look at something that when you're doing your evaluations, you have this tool that you can put into place that's giving you real data that we can then provide to our payers, to our insurance, to anyone who might be helping fund CRT. And the biggest piece is we're looking at the different pieces of CRT, focusing on function, the environment, participation, all of those client factors. So not just that diagnosis code. And that's what I would say anyone here who's a therapist would probably agree. We like to see the people. We don't like to see the ICD-10 codes. Those are fine. Those are useful, but we care about the people. So why does it matter? You can probably guess. We're going to do this by looking at a case study. So we have Jane Smith, obviously not her real name. She's a 75-year-old woman, 330 pounds, 5'5". History, COPD, osteoarthritis, lower extremity lymphedema. It's pretty significant. She's been using a group 2 power chair for the past 5 years, comes into the clinic and is in need of a new wheelchair. Pretty standard. So do the evaluation. We're running through standard assessments. Let's say decreased range of motion, both of her shoulders and her knees, generalized weakness. She's unable to independently reposition herself right now. She's also unable to maintain pressure relieving positions. Lymphedema is getting worse because she can't elevate her legs in her group 2 chair. Now here's the kicker. She has caregivers, pretty reliable in the mornings and the evenings. During the day, questionable at best. I'm sure many of you have heard this before. She needs a lot of assistance for her transfers. And she knows for her lymphedema, the best thing she can do is keep her feet elevated. Because she doesn't know if someone's going to be there to help her transfer, she stays in bed because she has no other way to elevate her legs. So she stays in bed right now for days on end. And guess what? She's developing a wound. And I will tell you that this is actually based on a case, and this is walking through exactly what happened with this case. So she comes in, talking to her and say, well, there's a pretty obvious solution. And most of you are probably thinking, well, what does she need? Well, she needs a group 3 chair. She needs all the seat functions. She needs to be able to reposition herself. She needs to be able to elevate her legs so that if she has the reliable caregivers in the morning and evening who can get her in and out of her chair during the day, she can be independent. Makes a lot of sense. But you saw what her diagnoses were. So guess what happened? I went off to insurance. Did they approve it? No, of course not. That was an immediate denial. And that is why we're doing this. The denial letter said she didn't have the underlying condition. She didn't have the diagnosis. And I would push back. Now, she did have an underlying diagnosis that affected multiple limbs. She was developing a wound. She's at pretty high risk, and it's going to get very expensive very fast to deal with that. So why are we just looking at those codes? So we're trying to move away from that. So now, where are we?
Well, some of you may remember at last year's ISS, the team presented an overview of the whole process for development of the SMI. For those of you who missed the presentation, we're going to give you a very brief run through of the work leading up to where we are today, and then we'll get to the updates that you've all been waiting for. We'll start with our systematic review and work our way to our current status with the development of the Seating and Mobility Index and the plans for moving forward. As we've mentioned, the core of our instrument development revolved around the ICF domains. We took what we knew about the limitations of current seating and mobility evaluations, documentation, and funding, and we aimed to develop a tool that would allow clinicians to assess and quantify a person's need for seating and mobility equipment, not based on their diagnosis alone. The review process was driven by our overarching research question for studies within the ICF context. We started the process by creating our inclusion and exclusion criteria for our review. Our search terms included those key elements of functional and objective clinical assessments to discover what existing tools, outcome measures, and home or environmental assessments were currently in the literature. We excluded those studies that involved therapeutic intervention, education or training, pediatric specific populations, product development, or articles prior to 1995. We utilized this method of review so we could provide an unbiased assessment of the seating and mobility tools that exist in the literature. For any researchers out there, you understand this is somewhat a rigorous process, but the quality of assessment was an important thing. We completed the key elements of the systematic review process by utilizing a web-based software platform in Covidence to search for existing tools in the literature related to CRT evaluations. After searching our criteria in Covidence, we reviewed 734 abstracts for relevance to our ICF domains of body structures and function, activity participation, personal and environmental contexts. A minimum of 2 reviewers was required to screen these abstracts. We only included those articles that were peer-reviewed, utilized standard tools, involved CRT seating mobility populations such as neuro or orthodiagnoses, and the scope and the design also needed to align with 1 or more ICF domains. With further full text review of 205 articles, we were able to exclude 86 articles due to either poor study design, intervention, irrelevance of the measure, wrong indication, or wrong outcomes for seating and mobility assessments. This time, 1 reviewer completed the full text review and then presented the details to the team for their concurrence. This left us with 119 studies for further review of the tool properties.
So 119 studies, that's still a lot. So we had to narrow those down. We took and categorized them into the various ICF domains: body structure and function, activity and participation, personal environment. And as you can imagine, there was overlap. And some of these articles mentioned the same tools, some crossed multiple domains. So in the end, we narrowed it down to 55 unique assessment tools. How many of you want to administer 55 assessments to your clients? Anyone? Anyone? No? Okay. So we had to cut down from there. Made a table of all of the tools. We were looking at the different components of each tool. So what type it was. Was it a clinician report? Was it self-report? How long did it take? 5 minutes? Not bad. 3 hours? Not going to go so well. Looking at equipment and space. Looking at how much it cost. Did it involve sending someone halfway around the world to get training for it? All of those factors. Now, there's no way to put that whole table up on here. So your eyesight, well, thank you for this. This is just a quick summary so you can see how we did it. So we took all 55 tools, put it in that table, then we could go through and review them. We took it to a team of seating and mobility experts. Some of you may have been a part of that. Reviewed each tool to determine if it was helpful, if it would be something that was useful to justify the need for CRT. Our advisory board and other clinical groups gave us feedback. So our final list included things that were validated as seating and mobility measures or in that population. They were tools that could be used to help justify the need for CRT. They were practical for clinical implementation. That's a big one. And there were tools that obviously had strong methodology, reliability, validity. So we got down to 41. You're going to administer 41? We're doing better here? So Julie's going to explain what happened next.
So what we did next was we created a clinician survey to allow experienced seating therapists to rate these tools. The survey was distributed to clinical experts in the field, asking them to rate the tools based on several things. First, the degree of current use or how often they used it in their practice. Second, Was the tool meaningful? So was it helpful in justifying the CRT? And third, how burdensome was the tool to use, both for the clinician to administer, as well as other burdensome factors, such as time to complete the tool, the space needed, special equipment, training, etc. We had a total of 34 responses. Results of the clinical survey identified 19 assessments that raters indicated were something that they used in practice, that they were useful for justifying CRT intervention, and was no more than minimally burdensome. These 19 items were further reviewed and condensed by a team of clinical experts, leaving us with an end result of 16 items. The scoring of these 16 tools was then recoded into a standardized scale, which is then being used to form a composite SMI score. The SMI score will help guide the clinician and supplier toward a specific type or category of CRT, and will hopefully provide the payer with the results of validated and standardized tool that can indicate to them why the specific CRT is necessary. Again, we want to move away from the diagnosis-based criteria. So you probably all want to know what were the final 16 assessments, but we're keeping that under wraps for now. As we'll discuss later, we will be doing validity testing with clinicians, which may include some of you. Because of that, we don't want to give away too much too soon. However, we can tell you the categories of these assessments. If you look at this list of categories, you'll probably notice that these align with what you're already completing during your CRT evaluations. It was important to us that the tool we are developing is something that will be easy for current seating clinicians to implement into practice, and something that novice clinicians will feel comfortable doing and will help make appropriate CRT recommendations. The SMI score will help guide the clinical decision-making and reduce reviewer confusion, which all too often, as we know, can lead to denials based on lack of understanding of the CRT documentation, because currently there is no standardization.
All right, I'm excited because we said everything was top secret and we still have most of you in the room. That's a pretty good sign that you're still interested in what we have to say. I'm guessing the question now is, well, what is the SMI if you're not going to tell us what those assessments are? So we're going to tell you what we can. The first thing you need to know is that the SMI, the Seating and Mobility Index, is not designed to be a standalone tool. This is not something where you pop out a score and you just send a little Post-it note over to insurance and say, hey, the score is 47, please pay for this. That'd be nice, but that's not what's going to happen. We intend for this to be something that is used in conjunction with the documentation that is already occurring, but again, as a way to quantify what we're doing, provide support away from that diagnosis. So if you go back, remember that systematically developed tool, clinicians assessing, blah, 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 yeah, getting back to that. So this is that tool piece. This is the assessment. This is the quantification. These are all the factors that we know as clinicians are most important for determining the most appropriate CRT. Now, if any of you were here, or virtually, it's nice to see you all in person, last year, you probably saw that. That's where we started when we started conceptualizing what the CRT would look like. Now, does this look complicated to any of you? Yeah, okay. It looked complicated to us too. So after sitting down for a while, talking it through, we decided that this was not something that would be realistic or feasible in practice to say, all right, pick something from column A and column B and hold on, we need to think about column C over here until we have something that we can come to a consensus about for all of our clients. We decided to simplify it. Okay, easier? We're good now? Got the simple table here. All right, got some head nods. So again, sorry, we can't give away too much, but what we're thinking is the SMI is a way to organize the data that you're already collecting. So just show of hands, how many of you do something like the tug, the timed up and go? Okay. And what's that measured in? Seconds? Okay, just pop quiz. How about manual muscle testing? Who does that? All right, what's that measured out of? Yeah, out of 5, right? How many of you have done the Borg? Not as popular, a couple. What's that scale? Good question. So 6 to 20. All right, so we have seconds. We have scores out of 5. We have 6 to 20. How does that become one number? That's the big question. And so that's where we take this table here. We have our standard score, which is what you would get when you're administering those assessments normally. And then the SMI tool helps convert that to a scaled score that can take all of those different numbers and turn it into something meaningful, summarizing all those assessments. So let's talk about how this fits in with documentation, because like I said, not a standalone tool.
So originally, documentation was outside the scope of developing the SMI. But as we worked more and more on the tool, we realized that you can't have one without the other. As you can see, some of the limitations of current policy are that the individual has to have a qualifying diagnosis in order to obtain a specific piece of equipment, which is very complicated and restrictive. How many of you have seen these before, right? In addition to having the right diagnosis, you also have to have policy-specific documentation by the evaluating therapist in order to obtain specific seating components or accessories. And although specialty evaluations that you do typically provide multiple measures of function, like Julie was describing, these results don't always provide clear rationale for the necessary equipment. So having a standardized measure would help facilitate an objective review, approval, and payer coverage for the provision of CRT. As we developed the SMI, we were cognizant of the fact that the SMI is not designed to be a standalone tool, as we've said, and the true power of it is when it's combined with a strong letter of medical necessity. The team of therapists working on the SMI are from 3 different universities and have 3 different styles of documentation. I imagine if we polled all of you today, we'd come up with a dozen other documentation options. These therapists have been working on a united documentation template that will combine information from all 3 universities. This will include the necessary elements of a seating and wheeled mobility therapy evaluation. It will contain the SMI as part of the assessment to help determine what CRT will best fit each individual client. Keep in mind again that the SMI is meant to help guide the clinician and offer validated, objective functional data. It is not expected to be used as a standalone tool or to guarantee the best clinical outcome, and that the clinician should take all factors into consideration when making their recommendation. It is expected that this template will be usable across several EMR platforms such as Epic, as well as templates developed in Word for clinicians who do not have access to EMR systems. So we don't expect your eyesight to be good enough to see all this, but here's an example of what we mean by a documentation template. There are spots for therapists to enter all relevant information, whether by typing directly or by setting it up to populate from an EMR. As you can see, the assessments included in the SMI are integrated directly into the template. While I can't speak to all EMRs, at least in Epic, it is possible to automatically pull the SMI assessment results and compute a summary score. However, we are designing the SMI tool so that this could be easily calculated by hand if needed.
All right, so let's go back to our case study. So we have Jane here again, and let's say we did the same assessment we did at the beginning, okay? And we know she needs a group 3 chair. So we run through, and here's where you see, we have seconds, we have scores out of 5. We have all of this information. Some magic happens. Yeah, there's magic back there, sorry. Can't show you what's behind the curtain quite yet, but that gives us this composite score. Maybe it's 104, maybe it's 372, whatever it is. This is something that indicates that she would benefit from a group 3 chair because we've included all of those measures of function. We've included information about her wounds. Every piece of that goes into computing this. So we put it into our documentation. We can pull in the individual parts, and then we have our summary score. With this, we'll have standardized language indicating that a score within a certain range, and we're not saying it's going to be the number 42 is X. We're given a range here because we have lots of factors to consider, but we're indicating that someone falling in this range would benefit from that equipment. So, assuming we do all of this, we submit it, we're in our happy little world where, our practice is influencing policy, and magically it's approved. And I know right now we're still in the preparatory phase of this, but the idea being that we can support our documentation with that information and using this measure, say, this is why we're recommending it. But someone will inevitably ask me, or at least I hope you're thinking it. What about your client who wants a scooter? Because you all have that client who wants a scooter. You know it. You're all thinking of one right now. Okay. There are a lot of reasons why we may say a group 3 with all seat functions is going to be the best option, or an ultralight manual wheelchair is going to be the best option. And someone says, no, I really want my scooter. Maybe it's transportation. That's a big one. Maybe it's caregiver availability. Maybe it's the home setup. Maybe they've had a bad experience in the past with a different type of device. Whatever the reason, we don't want to say that that magic number we popped out says they have to have that device. Because we know as therapists, just because it says someone would benefit from a certain type of CRT, if we give someone the CRT they don't want, makes a great clothes holder, collects a lot of dust, and then you have to dispose of those batteries eventually. That's not what we're here for. We're here to do the best we can for people. And if that means we're going to go down the scooter route, I mean, that's a different discussion, but we do take that into consideration. And that's why we're tying this all together as one. We're looking at that holistic approach to our clients. Again, not just the diagnosis. So what's next? We made it through sort of the first phases of creating the SMI. And now the reason we've been withholding information is we've been presenting to stakeholders and getting feedback, and we're going to start our inter-rater reliability testing. What we're doing is developing a number of case studies, and we're going to have clinicians use the SMI tool to go through those case studies to come up with that number. We're not saying what the number means, but we also want to see what someone would recommend without using the SMI. So again, you go through the case study, what would you recommend? And we'll see how that matches across cases and clinicians, and then comparing the results of the SMI score to what the therapist would recommend. So hopefully you'll be a little more forgiving now of the fact that we didn't tell you everything you were hoping for today. So we'll be doing that. We hope to complete that by the end of the summer, do our data analyses, and move towards publication.
Are you still with us? We're almost there. To wrap this up, so we've done the groundwork to develop the SMI, and now it's time to put it to the test. We expect the SMI will be a valuable tool to help guide clinical decisions for appropriate CRT based on an individual's function instead of diagnosis. It will help standardize documentation and allow clinicians and payers to speak the same language. If you take away anything from this, remember that CMS currently fails to consider functional mobility, complex medical needs, activities outside the home, or comorbidities in order to qualify a person for necessary CRT. We have been hard at work developing the SMI to more accurately reflect a person's needs so that clinicians can provide clearer documentation for the payers to bridge the gap and contribute to more equitable coverage for those who rely on CRT to live their everyday lives. We encourage you all to visit our CRT policy website to view the latest news on our project. You will also find a list and links to valuable resources and consumer advocacy groups. Our study will assist you with providing a tool for seating and mobility assessments, but the real change in policy lies in those groups who work endlessly to advocate for change on behalf of our end users, most importantly, the end users themselves.
Oh, please stay there for 1 second.
Yeah.
There's still a couple cameras out, so I want to make sure everyone got that.
Oh,
Good? Okay.
thank you. We would like to thank all of our stakeholders in the industry who have partnered with us to provide feedback and support toward the success of our study. You will find these partner sites on our CRT policy website. We would also like to take this time to acknowledge our lead investigator, Mark Schmaler, and his right-hand woman, Rachel Hibbs, and our entire collaborative team from University of Pittsburgh, The Ohio State University, and University of Michigan. We also sincerely appreciate the support of this valuable work by the Department of Rehab and Research Programs on Healthcare Policy and Disability.